Now let's turn our attention to the CMS program for physicians. This is based on the Medicare Access and CHIP Reauthorization Act of 2015. While this relates to physicians and not hospitals, hospitals should understand MACRA to assist their employed physicians and to offer support for physicians in affiliated networks and independent physicians in their community. So with respect to physician payments, MACRA is the legislation that repealed the sustainable growth rate for physicians and certain other provider individuals, locking rates at 0.5% annually through 2019, after which physicians are encouraged to shift to one of two tracks under the new Quality Payment Program. These include Merit-Based Incentive Payment System, or MIPS, which combines the Physician Quality Reporting System, Value-Based Payment Modifier, and EHR Meaningful Use programs. The result is scoring for quality, cost, improvement activities, and advancing care information. Relative weights for each category will change over time, and penalty is starting at 4% deduction, and bonuses as high as 12% will grow over time. And CMS is in the process of simplifying participation. The other track is the Advanced Payment Model, or APM program, which is for physicians who are already a part of a risk-based payment model, such as the MSSP Accountable Care Organization, Patient-Centered Medical Home, or other specified program. They may qualify for the APM track with greater financial reward and exemption from the MIPS requirements. Starting in 2019, physician Medicare payment adjustments will depend on which track the physician's group practice is in based on 2017 data. It is noted, however, that low-volume groups, clinicians in their first year of Medicare, and those in exempt payments are excluded. However, solo docs and small physician practices with 10 or fewer doctors can join virtual groups with only one of the members being eligible for the APMs in order for all the physicians in the virtual group to become eligible. For those of you wanting more specifics on CMS, MIPS, and APMs, especially as regulations seem to change every year, please refer to the cms.gov fact sheets. I also find that the American Medical Association and the American Academy of Family Practice have many very useful resources, including calculators and tools, and membership is not required for most of their materials. Now let's take a look at bundled payment. Bundled payment is an arrangement designed to pay multiple providers, including physicians, hospital, and post-acute providers, such as rehab facilities, skilled nursing facilities, home health, for coordinating all the services required for a single predefined episode of care, such as maternity care, joint replacement surgery, etc. Two strategies for defining the amount of payment are used. Prospective payment creates a budget for each bundle and pays that out when the episode of care criteria are reached. Retrospective payment calculates the fee before the episode begins and reconciles this against fee-for-service claims to determine any shared savings after the episode of care ends. There are also two types of payment arrangements. In one, health plans reimburse one entity, such as a hospital, involved in the care, and then that entity apportions payment among participants. In another, health plans reimburse each participant separately, but adjust the total for each to not exceed the predefined reimbursement amount. Which is better should consider the agreement that can be made with the entity receiving the payment and understanding the ability of the various participants to control services to produce positive results. In all cases, providers who exceed the prearranged reimbursement bear financial responsibility for the overages. Microeconomic challenges and benefits in bundled payments exist. A challenge directly impacting each payment is managing costs for a patient's care that may be out of the provider's control, such as medication adherence or other patient behaviors that lead to adverse events. Overall, predicting a patient's risk in advance can help decide whether to include the patient in the bundled payment model. But this may be difficult to do, at least in the initial stages of value-based care. Increasing provider communication and care coordination to ensure patients are treated optimally at every step in the episode is essential. The intent of bundled payment is to encourage standardized, cost-effective care, yet the level of standardization required is a concern of some physicians and some hospitals regarding the mandatory nature of some of the bundles. Other macroeconomic risks include potentially increasing the number of medically unnecessary services, such as joint replacements, even as there is strong incentive for discouraging unneeded services within the bundle. Potentially skimping on services needed for optimal outcomes is also a potential risk because today's bundles do not have a quality outcomes component. So what are the keys to success in bundled payment? In selected studies of the Medicare Bundled Payment for Care Improvement initiatives, bundled payments do seem to be successful. It is noted, however, that while CMS has been busy creating bundles and has several initiatives underway, the primary initiative for which there are results is in the area of joint replacement. For example, episode expenditures declined nearly 21% for lower extremity joint replacement without complications, and nearly 14% for those with complications. That's really huge. Episodes with prolonged lengths of stay decreased 67%. Rates of readmissions, emergency room visits, and severity of patient illness did not change significantly. Average post-acute care spending declined 27% per case, but only when bundles included financial responsibility for the post-acute care. The results of the Medicare initiatives, however, do contribute to identifying key factors for success. Some of these include participants need to be innovative with new programs such as hospitalists, care coordinators, patient navigators, facilities tailored to bundles, technologies to interact with patients. Participants also need to be interested in value-based care and willing to collaborate even with their competitors. Payment arrangements should also encompass the entity of treatment needed. Payment for good outcomes reflect patient risk factors such as age, health status, and social factors. Cover the entire cost of the episode, excluding unnecessary services, but with potential for a bonus if providers are more efficient or effective. And not hold providers financially accountable for treating unrelated or catastrophic situations. Going forward, hospitals, which have generally been the leaders in adopting bundled payments because of their frequent surgery components and the hospital's ability to take on greater risk, need to select carefully the conditions to be bundled and what providers and services should be included, especially figuring out how to ensure provider accountability. Much needs to be understood about the payments, including their timeliness, how they are set, whether they will be risk adjusted, and what data are needed to support analysis and ongoing understanding of results of bundled payments.